Hello, I am Dr. Chad Gehani, President of the American Dental Association. The COVID-19 pandemic has changed the way we live and work. This has been a very difficult time for the dental community. But from one practicing dentist to another, I would like to reassure you that ADA has our backs, and our association is working to ensure that you have what you need to navigate these times safely. On April 1st, we issued interim guidance for performing urgent and emergency procedures at this time. Today, we have assembled a panel of experts to answer your questions about the interim guidance. Now, I would like to welcome the ADA's Executive Director, Dr. Kathy O'Loughlin, who will serve as today's moderator.
Thank you, Dr. Gehani. In the last several days, the ADA has received a number of questions about the interim guidance from dentists all over the country. To best answer these questions, I'm pleased to be joined by three leading experts in the field of dentistry who helped develop the interim guidance we are discussing today. Dr. Mia Geisinger, Marcelo Araujo, and Dr. Dave Preble. Dr. Mia Geisinger is chair of the ADA Council on Scientific Affairs. She is also a professor and director of advanced education in periodontology at the University of Alabama School of Dentistry. She received her DDS from Columbia University School of Dental Medicine and her certificate in periodontology and Master of Science degree from the University of Texas Health Science Center in San Antonio. Dr. Marcelo Araujo is the ADA Chief Science Officer, CEO of the ADA Science and Research Institute, and the CEO of the ADA Foundation. Dr. Araujo received his doctorate in dental surgery and earned a certificate in periodontology at the University of Gamafio in Rio de Janeiro, Brazil. He received his PhD in epidemiology and community health and Masters of Sciences, Oral Sciences, from the University of New York at Buffalo, where he also completed a 2.5-year fellowship in periodontology research and teaching. Dr. Dave Preble is the Senior Vice President of the Practice Institute in his 15th year at the ADA. He practiced dentistry for over 20 years, holds a legal degree, and is a certified association executive. Dave is a fellow of both the American College of Dentists and the American College of Legal Medicine. Thank you all for joining us today. How would you summarize the interim COVID-19 guidance recently released by the ADA?
Well, Kathy, I think this document summarizes not only what the science has provided so far in terms of data related to COVID-19 and dentistry, but as well as what the regulatory agencies and other healthcare agencies has provided to healthcare professionals on how to reduce the risk when treating their patients. Specifically, I think the flow charts, what we are calling them the algorithms, they help the dentists understand what are the steps and what are the right questions they have to ask their patients when treating them during an emergency procedure. We really need to focus on reducing the risk of contamination for both dental professionals and the patients and make sure that we can control this the outbreak of the virus.
In terms of emergency and urgent procedures, don't these procedures produce aerosols that put ourselves, our teams, and any subsequent patients entering our office at risk for COVID-19 transmission? Dr. Geisinger?
That's certainly a concern, Kathy. And, I think that if you look at the third algorithm, this type of care without appropriate PPE does leave the clinician at moderate to high risk. It is really the rationale for many of the recommendations that we have made in the decision-making process outlined in these algorithms.
So at this point, dentists are unable to obtain face shields or N95 respirators and other personal protective equipment or PPE. Hospitals and medical settings are the priorities for receiving this type of equipment. So who is managing the PPE shortage issue?
Well, in the immediate future, there's no real management going on because PPE availability is entirely out of our sphere of influence because of the factors that you mentioned in your question. But ADA is in contact with the Dental Trade Alliance and all of the suppliers of this equipment, so we can at least stay informed about when the supply and availability will become better for dentists. We're also looking into the possibility of developing some sort of affinity programs with PPE suppliers.
The ADA is recommending that members wear surgical masks, if available, and N95 respirators for all procedures. The recommendations also suggest that surgical masks should be disposed of after each patient. How can the ADA provide these recommendations when frontline hospital workers can't even get proper PPE to treat known COVID positive patients?
Well, Kathy, I think one of the things we have to have in mind to start is the distance between the dentist and the patient during treatment. We're in very close proximity, and we understand now that the CDC and other government agents are also considering talking and breathing a potential aerosol producing action. So we really need to ensure that our dentists and our members and their patients are safe, but most likely is to ensure that the treatment can be provided into the low risk environment.
Are there any options for dentists to consider beyond N95 respirators and surgical masks with face shields?
Yes, last week the FDA announced emergency use authorization of KN95 respirators, commonly manufactured in China. These are similar to the N95 respirators in terms of particle filtration, but just like an N95, it's important for the user to do a seal and fit test after donning.
Kathy, may I add something else to this? One of the questions I was asked this week was related to the difference of what they are being called N95 masks and N95 masks with a respirator. What we see is that if you look into the two devices, they are very similar. The main difference is that N95 is a respirator. You will see is the one that on the front, on the area of the mouth, it looks like there is a filter. So when the person is breathing through the mask, there is another layer of filtration happening for this. So far, as we look into the science and the difference between the two, we haven't seen much more difference between them, as both type of masks are meeting the standard. And we are trying to ensure that not only our recommendations are based on science and publications, but also looking to what it is that there is the standards. That's why it's so the importance of ADA and C standards and other things here highlight the fact that we can help decrease the trend.
So it's likely that this will be the new standard for PPE in dentistry, since this has not been recommended to now? Could you just confirm?
I believe it will be. None of us have a clear crystal ball, but I think I would just turn the question around. Now that we know of the presence of this sort of respiratory disease that can only be filtered properly through the N95, wouldn't we want it to be the standard, I think is the better way to say that.
In the algorithms describing how to triage and screen patients and also manage the transmission of COVID-19, why is the ADA recommending that people who are suspected to have COVID-19 be sent to the emergency department for dental treatment?
So if you look at that algorithm too, the decision switch point is really the signs and symptoms of acute respiratory distress, respiratory symptoms. And in patients that have a fever and those symptoms, or even without a fever and those symptoms, going to the emergency room is critically important to make sure that they are screened and receive the care that they need for their overall health. and then their dental needs can be addressed subsequently based upon the findings of those investigations.
The interim guidance indicates that if a standard surgical mask is used during an aerosol generating procedure, then the patient needs to get tested for COVID-19 because it is a moderate to high risk situation for the health care provider and subsequent patients and staff members. How am I supposed to require subsequent patients to be tested for COVID-19 when it's already extraordinarily difficult to have that testing done?
Well, that's an important question without an easy answer. The idea behind using a surgical mask only, without a face shield, without goggles, without all the other things that you would need to bring it down to a moderate risk, is one of those things that the dentist would likely have to evaluate whether they want to do that procedure at all with that level of protection. The burden that this testing would place on the hospital system is something that there's no real way around. We obviously want to deal with dental emergencies to alleviate that burden, but do it in such a way that the dental team is not at a high risk.
If a rubber dam is used concurrently with the high-speed handpiece and the tooth has been disinfected after application of the rubber dam, is the risk level the same, and does the patient still need to be tested?
Well, the rubber then adds another layer of protection for both sides, for both the dentist and the patient. In terms of the algorithm, what we have seen is that we are focusing on the protection to the dentist, and that's why the use of mask and face shields, etc. If the use of rubber dam is added during the procedure, I think it's important that the dentists understand that they need to figure out the best way to treat the patients, to reduce the issues that they need to be treated, and at the same time protect themselves. So yes, the level of risk may reduce. We are basing this on anecdotal data. We don't see a lot of publications related to this. But in discussions that we have had with clinicians and others, we see that they may help reduce the risk.
In relation to rinse protocols, is the evidence informing the use of hydrogen peroxide and povidone related to their effect on viruses like COVID-19?
Well, there aren't any clinical studies supporting the virucidal effects of any pre-procedural mouth rinse against SARS-CoV-2. However, since SARS-CoV-2 may be vulnerable to oxidation, commonly used pre-procedural mouth rinse such as 1.5% hydrogen peroxide rinses may be considered, but considering that the microscopic particles that we're trying to be protected from are coming from the patient's lungs, a mouth rinse is not going to be a panacea unless you're going to have the patient rinse after every breath they take.
Can we add something else to this? Is you have to understand that the difference between a virus and other type of microorganism, and the virus is basically what we're seeing is that it's a layer of fat with RNA inside. And these two rinses have been able to break down that fat that creates and protects the RNA, which is very, very important for the multiplication of the virus once it invades the cells. So the assumption that there's one of these two viruses will kill, these two rinses will kill the virus is based on their action on peroxide, hydrogen peroxide in fat layers or povidone in fat layers. We don't know a lot about how other type of mouth rinse. Once you rinse, you may decrease in the risk at that point, but you don't know what's happening because the virus is on the lung, right? In the lung. And then if the patient will cough during the procedure, that virus the load may be exposed again because they're aerosol. So rinsing is good to start the process. And I don't know if Mia wants to add anything in there on the practice that she has seen, but I think it helps to understand how this two types of malpractices, why they have been said that they are potentially to control by.
And the only other thing I would add, Marcelo, is that chlorhexidine gluconate, which is a commonly used pre-procedural mouth rinse, has not been shown to be effective for virucidal action in these cases. So while that may be effective for bactericidal uses, it likely is an ineffective pre-procedural mouth rinse in this case.
Can the guidance flow charts be modified to include recommended procedures to avoid the generation of aerosols?
Well, so at this point, we're really focusing on the emergency procedures. But most important, the focus of this algorithm is to ask the dentist to use clinical judgment when deciding how to treat the patient. There are a lot of procedures there. There's a list of procedures that the ADA has identified as emergency procedures that we recommend that to be treated. But I think it's important that the dentists use their clinical judgment when deciding what to do. That's why it will be very difficult for us to include all of them in these algorithms. And we want to make sure that the dentists use this algorithm together with the list of procedures that we identify.
May I add also that considering that the definition of what is and what is not an aerosol producing procedure may be under closer scrutiny too, because in the medical world, if they're considering an intubation being an aerosol producing procedure just because you're in the patient's face when the patient is breathing, then this idea of aerosol producing procedures is not just what we do with handpieces or scaling instruments.
So what guidance should be given to a patient with a true dental emergency who is known to have an active COVID-19 infection?
So current CDC guidelines for both patients with known COVID-19 infections and PUI, patients under investigation for such infections, recommend that any necessary medical treatment be carried out in an air room, a negative pressure room, to reduce the spread of the virus in aerosols throughout the facility. And most dental offices are not currently able to provide that type of environment. So providing emergency care, even in very serious emergencies, for those patients in a private practice dental office, if those guidelines are not able to be met, does convey a risk to staff, dentists, and even subsequent patients for infection with SARS-CoV-2 and subsequent development of COVID-19. So individuals with an active infection need to be advised to go to their emergency department, contact them by phone prior, and learn what arrangements can be made for them to come in and receive the care that they need in the safest possible environment.
Why don't the recommendations from the CDC mention the use of rubber dam isolation?
At this point, the CDC Interim Guidance does not include the insight about how to provide safe care. We know that their recommendations are evolving. As of today, April 7th, we think that they are based on the publications that we have seen so far. But as during our conversations with the agency, we know that they keep monitoring the work. And we are trying through our members and other contacts that we have, understand if the use of rubber dam will add a real protection. I don't know, Mia, if you have seen any data or anything they can add.
No, I mean, currently their recommendations really don't delve into this very much, but I do think the rapidity at which some of these rapid reviews are getting out there into the scientific literature should help inform future evolving recommendations, both on the part of the ADA and on the part of national agencies.
Do you anticipate the ADA's interim guidance will remain permanent once things kind of come back to normal in a few months? It seems like running a dental practice under these conditions will be almost impossible.
Well, the interim guidance is informed by the latest recommendations from healthcare agencies like the World Health Organization and the Centers for Disease Control and Prevention, as well as the scientific literature. And we intend to revise and update them as new data emerge. So these recommendations are not necessarily going to be relevant after the COVID-19 crisis is over, but we have to understand that we will have learnings from this pandemic, and those learnings will influence how we move forward. What seems impossible now may not be what defines the future.
Dave, I'd also like to say that we may be looking at this from a static standpoint in terms of technology, but as this moves forward, we may also see advanced technology that that marries up with our advances in knowledge that allows us to have options that we currently don't have.
Well, I'd like to extend sincere thanks to all the panelists today. You were terrific. Thank you for doing this.
Thank you.
Thank you.
Thanks for the opportunity.
Thank you, Dr. O'Loughlin. And many thanks to our panelists for sharing their expertise with us. The COVID-19 situation is evolving and the ADA's work continues. Dentists like you are essential to the welfare of our communities, and our association will continue to support you. We will get through this together. Thank you for joining and stay well.